So ADHD and its pitfalls was the title I came up with for this. My name is Eric Messamore. The PhD is in pharmacology, and I say this because I love drugs. And I love drugs so much that what I love about them is two things. They tell you what's going on in a physiological system. So if you know what a drug does, and then you see that it changes some pathology, then you have a pretty good idea that the mechanism of the pathology was related to what the drug action is. Conversely, if the drug fails to do what you want it to do, that's a pretty good indication that the mechanism of the pathology that you use the drug to treat is probably not relevant to the symptoms that you're observing. And this is how pharmacologists view the world, and it's very interesting and exciting. The other thing I like about drugs is that they help people, and we all got into this business because we want to see people get better. And because of these things, I would like to just focus this talk on what I think is a story that is evolving and will end very badly when it comes to stimulants and ADHD. And in the end, a useful class of drugs will be demonized. And in the end, people who would be helped by these drugs are going to be not helped by these drugs. So I would like, broadly, this is going to help you to think more. To be careful around the assignment of an ADHD diagnosis, and to help you get, I hope, some deeper insights about what's going on in the broader world that I think is not so obvious to people who are on the front lines. So when I talk about what's going on with stimulants, I oftentimes get accused of thinking that ADHD isn't a real thing, and that's not true at all. ADHD is a real diagnosis; it's a real entity, and typically it occurs in children. And when you see that kid who can't sit still on 10 milligrams of dexedrine, it is miraculous. So it's really it's a real diagnosis, and stimulants are very useful medications. In fact, they are the treatment of choice for hyperactive childhood onset ADHD, and they're probably the best ever thing for the syndrome of apathy or indifference that oftentimes follows traumatic brain injury or brain injury from encephalitis. So brain injury is followed by apathy in many cases, and stimulants probably are the best thing for that. So they have the fabulously useful drugs. But also pain is real, and opiates are useful medications, and opiates can be the only medication that is appropriate for certain patients. For example, those that are intolerant of NSAIDs, who typically develop gastric bleeding in response to NSAIDs, and believe it or not, there are people who hallucinate in response to NSAIDs. And so they have their place. Ironically, from the point of view of opiate epidemic and backlash in 2018, the ironic thing is that for about 2,000 years in medicine, treating pain was the only thing that doctors could do well, and we relied extensively on opiate products for doing that. And now it's all topsy-turvy on account of they had been inappropriately used, and then there was a backlash. And as I think about the current landscape of controlled substances and societal attitudes to them, I'm struck by the fact that all these drugs on the table are controlled substances, which, with the exception of straight up hallucinogens like mescaline, can be prescribed by physicians. Amphetamines are trendy. They're usually seen as helpful. There's a lot of interest and enthusiasm building around the therapeutic use of hallucinogenic drugs like LSD or mescaline for the treatment of things like PTSD or depression. And also, there is enthusiasm which will reach fever pitch as soon as Janssen has approval for esketamine, which is on the horizon, and then we'll have a very interesting shift in how we view depression. Yet, interestingly, I still can't really see how it's possible to design a real placebo for a dissociative anesthetic or for a hallucinogenic drug. So on the one hand, we're kind of moving toward embracing these controlled substances, but on the other hand, are really loosening the attachment that we had to the concept of placebo control. There's not a placebo match for the experience of ketamine. So it's interesting that we're that we're doing this. Meanwhile, opiates, as everybody knows, are on the out, and there's a lot of press that says that benzodiazepines are bad, they are associated with higher mortality and dementia, and they should be avoided at all costs. And I find this a little sad because they are, for some patients, the best drugs available. But culturally, the pressures are high against prescribing these medications, either in short or the long term. So I'd like to bring your attention now to the stimulant phenomenon. And essentially, if you missed step 1, 2, 3, and 4 of the opiate epidemic, if you didn't have front row seats for the epidemic that is currently getting attention, well, just pay attention, because the same steps are being played out with amphetamine. We are, in my opinion, with amphetamine about where we were with oxycodone in 1999, 2001. So just follow the play and see what happens. We also, this is going to be probably the third major amphetamine epidemic in the United States. The first one was from about 1930 to 1970. The second one was in the 1990s, early 2000s, and this one bears a lot of similarity to epidemic number 1. I call the process indatrogenic, meaning that it's this epidemic is spurred not only by iatrogenic factors, but also by industry factors. And the steps of an indatrogenic process are as follows. First, industry obtains patent protection for a controlled substance that, in many cases, shouldn't be patentable. In the case of opiates, oxycodone, morphine, et al., were long established and available generically. The only tweak was a difference in the delivery system into a long-acting formulation, for example. And amazingly, they got patent protection for that. With patent protection comes big profits, which then goes with the ability to flood clinical journals with articles about the condition for which the drug is approved, and to flood CME conferences with up-to-date information. Largely, this is focused on establishing awareness in clinician minds about the possibility of ADHD or pain, as well, or bipolar disorder, as well as to kind of blur the boundaries around the diagnosis. Typically, these articles and CME activities will have as an end goal to try to get people to think that ADHD might not just be the hyperactive kid in the first grade that we learned in 1980. It could be the high school student whose grades are falling, or the college student who's has attentional issues. Similarly, or the next step in the process is to push for short screening questions that can be used to, again, raise awareness and try to motivate prescribing. In the case of the opiate epidemic, that was helped by the Joint Commission and the pain scale, as well as seeing pain management as a quality measure. And once a problem is recognized as a problem, then you will have governments will step in and they will try to restrict the supply and the access to the legal drug. This creates opportunities for what I call innovation in the marketplace. In the case, for example, of an example of innovation in the marketplace came from the problems of interdiction with cocaine. The solution to that was to get a cocaine-like drug that you could make locally from easy-to-acquire products. And in the case of the opiate epidemic, cutting down the supply of oxycodone from pill mills, and I'm not saying that was a great plan at all, but the unintended consequence of great restrictions on the easier supply and on interdiction is to just miniaturize the package. So it's, you can get carfentanil, you can supply an entire city with carfentanil needs in a small box of product, whereas it would have taken pallets of product to satisfy the opiate craving of a city if it was just standard tablets. And as you know, this is the problem. Now turning to the effect of patenting on the perceived prevalence of a of a disorder. I'm going to make the point that the ADHD diagnosis, or the estimated prevalence of ADHD, has massively expanded compared to where it used to be. This typically happens when drugs get patented. This is a really nice set of studies which look at the estimated prevalence of bipolar disorder from antiquity to the present day. The point of it is that up until 1996, bipolar disorder prevalence estimates were really tightly clustered around 1.5%. That was a kind of non-changing number. 1996 happens, and the significance of that is that, a generic drug, valproic acid, found a new formulation, divalproex, and that received patent protection. Abbott Laboratories then did what drug companies do, and they started to see to it that academic journals or clinical journals came out with papers which pushed the boundaries of bipolar diagnosis. And then you see what used to be a fairly constant estimate of 1.5% prevalence started to creep up to 6%, 8%, and so forth. And thus, the point is that when a drug gets the marketing/education activities result in more clinicians thinking that the disease is more prevalent than had previously been thought. This is an example of patenting generic drugs. In 1980, there were essentially 3 drugs: amphetamine, methylphenidate, and pemeline. But these 3 drugs resulted in 8 patented products, and that was the market in 1980. 2016, a couple of the ones from the left column got taken off the market, but they were replaced by others. So now we have 4 drugs. I count guanfacine and clonidine as the same drug because they're both essentially alpha-2 agonists. But you wind up with amphetamine, methylphenidate, alpha-2 agonists, and I'm blanking on the other one right now. No, actually, and atomoxetine. But 21 drugs, each with its own patent and each with its own marketing apparatus. That may be related to why a diagnosis of ADHD, which had historically been fairly constantly estimated at around 5% of the population, 1 in 20 individuals, began to increase in perceived prevalence. And again, to the historical estimate, this 1 in 20 estimate was consistent across many, many countries. I mean, this was a multi-decade, multicultural kind of flat line about what the prevalence of ADHD was. But now we've seen, 2 to 3-fold increases in the official prevalence estimates, and probably in the unofficial clinical practice, it's the number of actual diagnoses is probably increased significantly higher than that. In addition to the drugs being available, then ADHD popularity and stimulant use is helped by the fact that stories appear in popular press. So results from a Nexus search show that in major news outlets in the US, there were only 25 stories about autism or ADHD, whereas in 2000 it went to 800 or so. And the impetus for diagnosing ADHD has also been helped by the fact that it now qualifies for coverage of SSI and an Individuals with Disabilities Education Act. So what's bad about that? I mean, if you catch more people that have ADHD and get them treatment, that's actually really a good thing. But if you overdiagnose ADHD and if the consumer landscape is flooded with stimulants, this is the cause of an epidemic. This is an open access paper. You can get, by following the reference, nice historical summary of the first epidemic, which, like this epidemic, was caused by the partnership of industry and physicians. And stimulants were found useful for alertness. They were found useful in the treatment of depression. They were found useful in weight loss. Those were the 3 major indications, aside from the military use, which is actually quite widespread in World War II. But medical use for weight loss, depression, and so forth led to an epidemic. And highlighted in red, the current estimates of amphetamine misuse are now equal to the peak of the epidemic #1. So it really is a matter of time, in my view, before we become aware that we have an amphetamine problem in the U.S. Well, we have another amphetamine problem in the U.S. And why worry? My principal worry is that amphetamine causes psychosis, and people who use amphetamine long-term clinically appear to develop a schizophrenia-like condition that tends not to go away. In animal models, you can certainly show that long-term synaptic damage occurs from protracted stimulant use, and that seems to seems to be upheld in clinical practice, although there's very little human evidence that shows that whether very little human data to say whether long-term stimulant use produces visible changes in brain. Nonetheless, it does create psychosis. There's a massive disconnection, as folks know, between the world of clinical trial populations and real-world populations. So in clinical trials of ADHD drugs, they carefully choose their subjects, and they typically find that psychosis from therapeutic doses of stimulants is around 0.25% to 0.5%, not very high. But in real-world studies, naturalistic settings, the occurrence of psychosis from therapeutic dosing of stimulants in presumed ADHD may be as high as 5% or more. And it concerns me that as clinicians, we're more and more constrained in the time that we're allowed to devote to patients during encounters, which leads to the possibility of not having adequate time to explore all diagnostic possibilities in a differential diagnosis list. Attention complaints are extremely common, and they're probably more common in a world in which a lot of the peers of a young person in high school or college are finding that stimulants are very helpful for their mood, their energy, and their concentration. So presenting with a complaint of concentration impairment is common, and the complaint itself is relatively vague in that, it has a massive differential, which could include on the psychiatric side, depression, anxiety, nascent psychosis, bipolar disorder, family strife, or it could just be a normal variation of human attention. But when there are pressures to diagnose ADHD, or when there are messages in clinical journals that are indirectly sponsored by industry that suggest that the inattentive type of ADHD is just as bad as the hyperactive kind, and that it can be detected. And with this sort of softening of the diagnostic boundaries, stimulants get prescribed more frequently, I believe. And in addition to potentially missing a more valid diagnosis, the risk of prescribing for any population, but particularly the risk for prescribing for children and adolescents, is that when we assign a psychiatric diagnosis, which requires a medication to treat, this occurs at a time when an individual is forming their identity of their very self. And we run great risks of helping this individual to form a concept of self as somehow broken, as requiring external pharmacological assistance to be normal or to function normally. And nobody writes about this very much, but I think it's the thing that keeps me up at night when I think about childhood psychiatry and the transformation of that field from one which was extremely therapy focused in as late as 1990 to one which is increasingly prescribing focused. So those are, I think, conclude my thoughts about pitfalls around ADHD diagnosis and stimulant prescribing. Let me try to stop the sharing.